My remit today is to talk about novel concepts in gynecological ultrasound. Whenever we think about developments in ultrasound, we often refer to technical advances. And I've been in ultrasound for 35 years already, and I've seen a lot of exciting developments. I've seen real-time, I've seen pulse Doppler, color Doppler, power Doppler, elastography, 3D. And generally, if you look at this development, there's often great excitement which lasts for a year or two. Then there's a general cooling of the affection for new technique, and then it settles at a certain level, usually about 10 to 5% of contribution to ultrasound diagnosis. So there is lasting, modest, or mild development, mild contribution to diagnostic accuracy. There hasn't been in gynecology a major change in the last 10, 15 years. And I must say, for me, last 10 years have been most exciting ever in gynecological ultrasound. But I think what was the reason for this drive, this change? There are many factors which play in this process. There is a constant drive for improvement driven by research and enthusiasm of clinicians. There are also women expectations, health economics, which are helping us to progress. Of course, experience and skill increase with time, and therefore we do better. But what has been a major drive, I think, in the last 10 years is actually surgical advances, advances in minimal laparoscopic surgery, and change in clinical thinking. There's also been improvement in technology. There was subtle improvement in imaging, which are not very obvious to all of us, but I'll illustrate them in a second. And also information technology, ability to look at the database, to analyze the images, and learn from experience has hugely increased our competences and our knowledge. These are two images of uterus, which are obtained by top-range machine. The first one is from mid-90s, which was the best machine money could buy, and this is our standard machine on the right. The amount of detail, ability to analyze uterine architecture, and the medial-by-medial border, vascularity, has changed tremendously. As a result, we are now able to rediscover conditions which have been there for a long time, but we were simply unable to study them. And the most impressive example is adenomyosis. With the old machine, it is impossible to analyze subtle structures such as endometrial striations, small endometrial cysts, or look at the endometrial-mammalian junction. So with new technology, we have rediscovered this condition, and we are learning rapidly about clinical significance. Another example is ectopic pregnancy. And if you look at the work from early 90s or 80s, you will see that ectopic pregnancy was always perceived as a dangerous condition because the only ectopy we could see was a relatively large gestational sac, which often contained embryo. Well, the small, solid tubal miscarriage, which is this blue little line on the side, you can probably see it here, has hardly ever been seen. With advanced technology experience, this little tubal miscarriage has become the most common form of ectopic pregnancy seen in ultrasound scan. And this change in sensitivity, change in perception of condition, has influenced the change in clinical management. So in the 90s, when we operated or given methotrexate to every ectopic pregnancy, now our default position is to do nothing unless we are really convinced that ectopic pregnancy can do harm. If you look at our practice now, 1/3 of ectopic pregnancy in my department is treated without any intervention, without any care apart from support and careful follow-up. So the massive change in clinical thinking, massive change in management, influenced purely by quality in imaging and better experience. Diagnosis of fibroid is the bread and butter of our work, and we diagnose them every day in a number of women. And again, in the 90s, we were happy if you could diagnose fibroid and inform clinicians there is a tumor in the uterus, which could be a problem. Again, there has been a massive change in the last couple of decades. From hysterectomy, open mammectomy, we offer a number of choices to women with fibroid, such as laparoscopic mammectomy, hysteroscopic resection, vaginal mammectomy, embolization, MRI-guided focused ultrasound, and a plethora of new medical treatments. So therefore, saying somebody has fibroid is not enough. And the only way to provide meaningful clinical information is to look at every fibroid, measure it, and describe position, which is a real pain for my fellows and for less experienced operator, but clinician, if he needs information about fibroid to plan the management and provide effective care, needs this. He needs to know exactly where the fibroids are, how many there are, and how to approach them. new technology brings new challenges. And a few years ago, there was a case in America where somebody with uterine sarcoma was offered laparoscopic mammectomy, and medical legal case concluded this a lot of harm to women. And as a result, many people have stopped practicing laparoscopic mammectomy. We didn't, but we tried to rise to the challenge, and therefore, looking at the fibroid, now we try to also differentiate whether the fibroid is benign or malignant. It is possible, it's not easy, but again, advanced ultrasound imaging help us to overcome this issue. So if you look at the fibroids, there has been a massive evolution in the way we look at them, from the non-invasive diagnosis in the past. Nowadays, fibroid diagnosis require mapping, assessment of uterine cavity involvement. We need to help to select women for open laparoscopic surgery. We need to detect effectively uterine sarcoma prior to laparoscopic mammectomy. We need to assess them postoperatively to see if operation was successful, whether the cavity is properly restored, look at the adhesions. We need to also look for parasitic postoperative fibroids, which are quite common, and also something which is a problem which we faced more often than in the past is something called interval sarcoma, because women with benign fibroids after laparoscopic mammectomy tend to develop sarcoma a few years later. And also we need to learn more about natural history. What really shook the world of gynecological ultrasound was not ultrasound technology, it was change in the way endometriosis is perceived and treated. And the major change was laparoscopic surgery, which suddenly facilitated detection and treatment of endometriosis, which was impossible to treat in the past. And to provide effective minimally invasive surgery on endometriosis, you need to know preoperatively the extent of disease, organs involved, and severity of disease, because difficult endometriosis requires an experienced surgeon who operates in a tertiary endometriosis center, and therefore these women would benefit only from treatment if they are referred to appropriate person at the appropriate time. For me and many of my colleagues who practice ultrasound, this paper by this able, intelligent French radiologist was a huge embarrassment, because we realized that we spent many, many years scanning the pelvis and closing our eyes to an obvious diagnosis of deep infiltrating endometriosis. And this has been the most important change in gynecological scanning since the early 90s. And it has resulted in several important improvements. The first one, it signaled the end of transabdominal scanning. Transabdominal scanning full bladder has no role in diagnosing endometriosis, and the only way to deal with this condition is to do dynamic scanning, which you can see here, I hope, which involves palpation of the pelvic organs, careful assessment of the movement, and assessment of peritoneal structures and surrounding tissues such as bowel, bladder, and peritoneum. And with good technique, good imaging, and careful approach to the pelvic examination, we can now detect tiny subtle changes in endometriosis which are impossible to see or comprehend to be seen some years ago. But endometriosis scanning is a problem for us because it requires us to move from our traditional comfort zone, which is uterus and the ovaries, to other pelvic organs. We need to look at the bowel, we need to look at the rectovaginal septum, bladder, vesicular pouch, and abdominal wall. So we had to cross our mental barriers. And we have to accept there is more to see in the pelvis than uterus and the ovaries. And modern gynecologist in advanced practice has to look at the bowel, has to look at urinary tract, rectoperitoneum, and pelvic circulation. It is impossible to provide comprehensive assessment of endometriosis patient without being able to look at urinary tract. And we became very serious about non-invasive ultrasound diagnosis of endometriosis. I was told by my colleagues that it's very nice, but unless you can tell me about ureters and kidneys, I still need to do an MRI to assess patient preoperatively. So we made an effort and realized that ureters, which in most radiological textbooks are described as impossible to be seen on ultrasound scan, are that easy to see. And if you angle your probe a little bit laterally, it will take you about 2.5 seconds to find the ureter in every single patient. But not only to find the ureter, but also to diagnose ureteric pathology. As you can see, this patient, the ureter is slightly stenotic due to presence of endometriotic nodules. You're not going to find this on an MRI scan. You're not going to diagnose it by looking at the kidney because kidney is not dilated, but this is a disease which can only be detected in ultrasound scan. So ability to see the ureter has suddenly, in my practice, eliminated need for MRI in endometriosis altogether. So ultrasound, similar to fibroids, has evolved. In the past, diagnosing endometrioma was enough. Nowadays, we need to detect deep infiltrating lesions. We need to map them. We need to assess their severity. We need to plan the management. We need to correlate symptoms with the lesions. We need to look at women who are managed conservatively, look at the size of the lesion and response to the treatment. We look at women postoperatively because surgery is not always successful. And also we need to study natural history because endometriosis behaves actually very differently from what you would think is the case looking at the old anatomical and gynecological textbooks. There are unexpected benefits of looking further beyond the pelvic organs. For example, this is the two patients who presented with unexplained severe pain, and you can see in both of them we diagnosed very easily ureteric stones. Until 3 years ago, I've never seen ureteric stone ultrasound. Now this is diagnosed 1 or 2 every year. These women present with atypical symptoms. They're not referred to urologists, they sit in casualty. They see surgeons, gynecologists, there's agonizing diagnostic process. They suffer in pain. And if you do ultrasound scan like you see in these cases, you can make this diagnosis within seconds and help these women and shorten their suffering. Another surprising development we witnessed a few years ago is the diagnosis of pelvic vein thrombosis. Look at the ureters, you can't avoid but not seeing uterine arteries. And if you look at uterine arteries relatively carefully, you will see that some of them, you will find a massive blood clots. And when I showed this to my hematologists, they were holding their chest and saying, oh my God, this is really painful, this is really dangerous, we need to do something about that. So we spent a few years studying them. It's not such a serious problem as you would think, being traditional hematologist looking at the clots in women who have usually deep thrombosis in the veins. But it's potentially one of the most important advances that we have in our practice, because by diagnosing pelvic clots, we could perhaps save more lives than we would by looking at the ovarian cyst and fibroids. So this is an exciting development which has been brought not by our desire to expand our scope of interest, but simply as a side effect of looking at pelvis further and deeper than we used to. So we're in a strange position now, because gynecologists, we are now able to diagnose pathology in the pelvis, which is impossible to detect by any other means. And it's often scarcely believable to our colleagues that we can pick it up. For example, we can diagnose bowel polyps. And when I diagnose bowel polyps, they're often formed by surgeons who said, are you sure you can diagnose bowel polyp ultrasound? Because I've never heard of that before. Another very satisfying diagnosis is small bladder polyp. These bladder polyps are always considered malignant, and they're almost impossible to see unless you look at the ureters, you will find small polyp next to it. So our ability to detect pathology has greatly expanded. The difficulty, however, this is not an area that we are familiar with. Pathology we often don't understand. It's very hard to interpret. But nevertheless, we're in a strange position, the gynecologist. We can see pathology in the pelvis that no other imaging modality is able to detect or has ever seen before. But the quest for improvement doesn't stop here. And this is a lovely paper from Dr. Fischerova from Czech Republic, which showed that ultrasound can also go further. So if you're looking for gynecological disease, we cannot limit ourselves to the pelvis. Disease affects liver, affects kidneys, retroperitoneal space, lymph nodes, and the modern gynecologist's interest in oncology has to move further from the pelvis into the upper abdomen as well. A few years ago, my ultrasound gynecological reports were very short. Probably they belong as a clinical history on this report. This is the case I just saw a few days before I came here. You can see how much effort it requires to do a modern gynecological examination and describe all relevant pathology in appropriate detail. And life is not getting easier, but there's no doubt it's getting more satisfying, and the report like this is certainly more helpful to clinicians than what we used to in the past. So I'll conclude by saying that gynecological ultrasound has undergone fundamental changes in the last decades. I think main drivers for change have been developments in clinical and surgical management of common gynecological conditions. Subtle and constant improvements in the quality of beam mode imaging have facilitated diagnosis of subtle anatomical problems, which enable development of new diagnostic algorithms and novel management strategies. The techniques and scope of examination has changed from primary focus on pelvic organs towards comprehensive examination of the whole pelvis. And these developments are welcome from a clinical perspective, but they also pose new challenges for training of ultrasound examiners and also possible medical legal challenges with the misdiagnosis of condition, which we are not familiar with, and this needs to be addressed in the future as well. Thank you for listening.